Welcome to the doc2doc podcast. I'm Rob Hoyer, medical oncologist.
And my name is Abbas Shafi, gastroenterologist. This is a podcast about lifestyle medicine, disease prevention, and longevity.
This podcast is provided for informational purposes only. It is not medical advice. Please consult your physician for personalized therapy and advice.
Our goal is to enable individuals to become CEO of their health by managing their diet, exercise, sleep, and stress to prevent common disease.
Hi, everyone. Welcome to today's show, where we're going to speak about stomach, otherwise known as gastric cancer. This may not be one of the diseases that you commonly think about in general, or one that you may not hear about a whole lot. But gastric cancer, there's a couple parts of it we're going to speak about today that are really pertinent to lifestyle medicine and how you can prevent it. I'll let Abbas kick it off with both the anatomy and definition of gastric cancer. Then we'll talk about the incidence and of this disease.
Thank you, Robert. To understanding a disease is very important to understand the anatomy and physiology of the organ that is involved. Stomach is a muscular hollow organ in the GI tract, which is located after esophagus and above the small intestines. Its function is very important in digestion of the food. It performs chemical and breakdown of the food by means of enzymes and hydrochloric acid. There is two sphincter in the above and below the stomach that prevent from content of acid to reflux to esophagus or prematurely dump to the small intestine. The lower esophageal sphincter that prevent from acid reflux, as well as pyloric channel, which controls the passage of the food from the stomach to small intestine based on the acidity and the breakdown. The stomach cancer, as well as other cancers, they always start with inflammation. When the lining of the stomach becomes inflamed, then subsequently the cells start changing, and those intestinal changes in the gastric lining called intestinal metaplasia, and they are the precursor for stomach cancer. The stomach cancer is mostly adenocarcinoma. However, there's other type of cancers such as lymphoma, sarcoma, carcinoid, and rarely metastatic from other organs such as breast cancer can occur in the lining of the stomach.
So I'll just make a few comments about the incidence, and that means how frequently this condition occurs. So gastric cancer is about 1.5% of all new cancers diagnosed in the United States. And the average age when folks are diagnosed is about 68. And 6 out of 10 people diagnosed with this disease are over age 65. And there's a slightly higher incidence in men, about 1 in 96 versus women, 1 in 152. And it's really interesting when you look at the history of gastric cancer. Back in the early 1900s, gastric cancer was actually the number one cancer in the United States, and probably had to do with a high intake of salty and processed food is what we think. Today in Asia, gastric cancer is the third most common cancer and the second most common cause of cancer death. And the highest incidence rates are in Eastern Asia and other parts of Asia. We'll talk a little bit in a second about screening. In the U.S. we don't tend to screen for gastric cancer, but in Asia they do. I'll let Abbas comment about that.
In the worldwide, it still is the fifth or sixth common cancer in the world. The prevalence in U.S. and Western countries has decreased, possibly due to event of antibiotic and as well as hygiene. That's maybe the issue. And however, in Asia and Africa and other places, this is still a very common disease, and they screen much more frequently, and we'll get to that, how to diagnose this later on in our conversation.
Abbas, could you tell us about H. pylori? And I've always been fascinated by this bacteria. Can you tell us a little bit about H. pylori, what it is?
Commonly in the lining of the stomach, due to high content of acid, not too many bacteria can grow. However, this bacteria has develops a defense mechanism against acidity, has a filament around it, as well as flagella, which is like a helicopter that burrows underneath the lining of the stomach, so prevent itself from acid killing it, and then causes chronic inflammation. This bacteria is very, very common throughout the world, particularly in Asia and in Africa. And some of the community is 90 to 100% of people, they have this. In Middle East and Europe, probably 80-85%. In the United States, probably around 50-55%. And it's based on ethnic background and is mostly oral fecal contamination and eating from the same pots and pans and the same environments. You don't get disease acutely like any other bacteria. This is a very, very slow, repetitive, chronic infection. And due to chronic inflammation, initially can cause ulcerations and sometimes cause stomach bleeding, or due to bleeding and inflammation cause blockage. In the long run, that could be a precursor to the sloughing of the lining of the stomach and be a precursor for stomach cancer.
That's really interesting. I never thought of didn't know about that flagella with the little helicopter burrowing underneath the mucosa. That's what they call a helicobacter. It's like that's what the word helicopter comes from, as a helicopter. So this is a very smart bacteria that is has developed like a gel shape around it, as well as that causes burrowing. Then this is can survive the stomach acid as low as pH of 2 and to survive, and causes once they start replicating, then it causes inflammation and consequencing of sloughing off, called atrophic gastritis, and consequently probably due to chronic inflammation is become a precancerous condition. So it's the high inflammatory environment that's associated with the cancer.
Correct.
And whether it be H. pylori or acid reflux or both, are they additive if there's more than one inflammatory condition?
Correct. Even you're taking some non-steroidal anti-inflammatory like Motrin, aspirin, that can cause also damage to the lining of the stomach. The same thing as smoking and chronic, even regular alcohol use. So this combination of all of those things, which cause inflammation and then consequence of chronic inflammation to the precancerous stage, and changing of the lining of the stomach, then consequently to stomach cancer.
Fascinating. And so it's so in the United States. So since the advent of refrigeration, the incidence of gastric cancer has dropped dramatically. I mean, it's like to go from the most common to, I think it's now like the greater than 10th. It's almost, I think it might be even the 20th most common cancer. It's not a very common cancer, but it's one that is, we'll talk about in a second here, is pretty challenging to treat. And
I think it's a combination of number one is hygiene. I think since World War II, they to develop the better hygiene for sewer system, for the toilet, as well as refrigeration, better cooking methods, as well as, I believe, associated with antibiotic, because of as we are using the antibiotic for many other causes, then was that this probably kills some of the bacteria. I never forget that when I was in VA hospital in Shreveport, my patient that had a chronic abdominal pain, at that time was just the beginning of identifying of the H. pylori treatment. He says, something, I've been suffering from my stomach ache for a long time. I had bad ear infection and they put me on strong antibiotics. After that, not my ear gut, my stomach, I have not had that stomach problem. Then later on, it was always thinking, maybe he had some H. pylori, and that give me long treatment antibiotic, and he got better. So if you look at the history in 1930s and 40s, Pepto-Bismol, which has some antibacterial effect, there was treating stomach ulcer or inflammation with that. Then went to the different type of medicine and diet, and then since late 1980s and 90s, then by finding the H. pylori, then we start treating just like an infection, and with multiple antibiotics, which is very difficult to eradicate this bacteria. So you cannot use one antibiotic. Sometimes you have to use 2, 3, and different modality to eradicate this. But however, this may be associated with the decreased incidence of stomach cancer.
So in a way, it really wasn't done as much on an individual level, but more of a societal level, that we applied a lifestyle medicine change.
Correct.
And that allowed us to greatly decrease
the stomach cancer.
Cancer.
Yeah. So yeah, it's I got some training in China as well as a little bit in Japan, and when you go there, the incidence is so high that they don't even do stomach biopsy because they cannot do a scope everybody. So they follow the blood serology, and if you start, they're using different method than we use here. So as soon as that peaks, they know get reinfected, and they treat aggressively the H. pylori. So I think the environmental eating plays, hygiene, as well as the H. pylori, that can be contributed to the precancerous stage. So I think the diet as well as the hygiene and all, I think that I think is by itself is maybe one, but I think has other cofactors to cause the chronic inflammation and atrophic gastritis, which is sort of burning out the lining stomach and then becomes precancerous.
So if someone has symptoms of, say, upset stomach, nausea, belching, maybe it's appropriate to get screened for this. But what if someone has no symptoms? Should they get screened for it?
Well, in Asia, because this is such a common prevalence of cancer, they get, as we do colonoscopy for colon cancer in West, they do routinely. When they go to their doctor's office every 6 months, and as the age progresses 6 months, but sometimes even every 2 years in younger age, they do either the blood test, or now we have a stool test, or they do conscious small endoscopy through a nasogastric scope, and they sample the gastric content to see and visualize to see whether you have H. pylori or precancerous cells. So in Asia, they're very aggressive, and the treatment is very aggressive. In the West, unfortunately, the stomach is such a big organ. By the time you get symptoms of gastric cancer, is usually in 3rd or 4th stage. So we don't have a protocol, but however, I treat my individual patient based on their ethnic origin, and I educate them that, if you have Asian background, you're 1st generation or 2nd generation, then I think you should use those protocols and to prevent stomach cancer.
So I'll comment a little bit about how we diagnose and stage this condition. And as Abbas said, a lot of times this disease is diagnosed when someone comes in with, they may have upper abdominal pain, unexplained weight loss. Usually it's in the stages 2 to 3 or even 4, which being advanced or metastatic disease. Unfortunately, when we see gastric cancer, sometimes it's picked up. Someone's having endoscopy and it's found, whether or not it may not actually be causing symptoms. Sometimes we'll find that rarely you'll find it on a CAT scan. You might see a mass in the stomach, but not very commonly.
CAT scan is not very sensitive, and the earliest, the symptoms, early symptoms pretty much can mimic, any dyspepsia, peptic ulcer disease, reflux. So the early stages but if it persists, I think it's very important that the individual talk to the doctor and do the physical exam, as well as do early preliminary result, whether screening for H. pylori or the treatment, or then if it's persistent, an endoscopy and tissue diagnosis. it is preventable if you can seek early detection and be cured in early stages. But unfortunately, this is in the West, stomach cancer screening is not a protocol that unfortunately has been developed because of such a low incident. And so we if once we diagnose them is in a later stage, but the individual should be, if they have persistent symptoms, have to exclude that. And the imaging study like CAT scan, they're not as sensitive for early stages as they do the endoscopy. But the H. pylori can be easy screened through the stool, and as well as if you even screen with the serology initially is very specific, but the sensitivity is not as good. But it can be a part of the routine screening to be done.
So when I see a patient with gastric cancer, the first thing we do is stage the cancer, and this is the T, N, and M stage. We talked about this for esophageal cancer, the T being the tumor, N being lymph nodes, and M whether or not there's metastatic disease, which means the disease has spread. So the most important thing to remember for gastric cancer is the staging is based on the depth of the cancer invading or growing into the wall of the stomach. And it's very important when you think about all the gastrointestinal cancers, we're actually talking about from the inside of the organ outward. And so it's all the cancers start on the inside. So inside the esophagus.
Most start from the lining of the stomach in the glands.
And so if the cancer is really what we call early stage, we call T1 tumor. Sometimes it can be removed endoscopically, endoscopic mucosal resection, where the doctor can remove a section of the inner lining of the stomach with a special tool to remove that area of the cancer.
And that's a very common method in Japan and Asia, has become past several years, in maybe past 5-6 years in the United States. But when you go over there and you see how aggressive by not only doing the endoscopy as well as called chromotherapy, which is as well with different wavelength of the light to catch the early stages of, and once they do that, they do the endoscopic ultrasound, which is an endoscopy with addition of ultrasound to see the depth of the cancer, as Rob mentioned. And if they catch it there, yes, the mucosal resection with follow-up is the treatment of the choice in early stages.
And I understand why they're so aggressive, because once the cancer becomes what we call T2, when it goes into what's called the muscularis propria, which is the muscle layer, smooth muscle layer of the stomach, that's generally when an oncologist like me gets involved, and we start talking about doing surgery, which is oftentimes what we'll do is preoperative chemotherapy, where we give chemotherapy prior to surgery. There's some quite good evidence that giving chemo prior to surgery is actually it has a survival benefit for this disease. So oftentimes we'll administer chemotherapy before surgery. If the cancer is spread to lymph nodes, we almost certainly will do chemotherapy before surgery. So there are situations, of course, if the cancer is bleeding or there's some urgent need to remove a part or all of the stomach, that can be done where the patient would have surgery first. But usually we'll try to do chemotherapy first and then do surgery afterwards. Survival after a diagnosis of gastric cancer is directly related to the stage. So the goal is to try to diagnose it early, or ideally prevent it. I wanted to ask Abbas how he aims to make a diagnosis early in his patients, and what you do when you find this condition.
Right. I think we always have to listen to our body. Our body doesn't lie. You just need to listen to your symptoms, how you're feeling. So if you have persistent symptoms, as we mentioned before, like abdominal pain, something called early satiety, when you eat food, that your stomach gets full, and weight loss, persistent acid reflux that does not respond to lifestyle modification, then you should talk to your doctor and to consider further evaluation. Commonly, we do a physical exam and get a good history. and to make sure the common reflux or stress management and all of that. But if it persists, then you need to have further examination. The common examination is endoscopy, which is a laryngoscope, which is very comfortable, and there's sedation most of the times in U.S. And I've done many of them in Asia without no sedation. Patients tolerate very well. It takes about 10 to 15 minutes max to good examination of not only esophagus, the lining of the stomach, and upper part of the intestine called duodenum. And commonly we biopsy the stomach for H. pylori as well as inflammation with the chronic or acute. And we send the tissue to the pathologist. And the pathologist will look at the depth of the biopsy that we take. We commonly, as Robert mentioned, we look in the lining of the stomach called mucosa. We look whether there's any bacteria, and if it is, of course, we treat that. Then we look whether there is a precancerous cells, which is called intestinal metaplasia, and that has different type of category. Then of course for cells, if they have any cancer, and then this you can do through the endoscopy and endoscopic ultrasound for depth if you have stomach cancer. And then with the newer immune studies and staining, then we can Rob can talk about more that helps with the treatment, as well as then go further to CT scan, PET scan to do a final cancer staging, then to see what type of treatment we can offer to the patient.
So yes, we're increasingly personalizing the treatment of gastric and other cancers. And one of the main markers that we look at, mainly for advanced or stage 4 disease, is something called HER2. And HER2 is a protein which is what's called amplified. It's a growth protein, and it makes the cancer. It's like think of it like a big on-off switch, or in this case, a big on switch for the cancer to grow very quickly. And there happens to be a medication called Herceptin, which or otherwise known as trastuzumab, which is used to treat this condition. And HER2 positive gastric cancer is about 20% of all cases in the United States, and the medicine definitely is helpful in conjunction with chemotherapy, and that's mainly in advanced cases when we test for HER2 and then use Herceptin. But when we are treating with earlier disease, we'll often use chemotherapy, as I mentioned, up front, and then surgery afterwards.
Great. I think we should go to, as anything else, to lifestyle. I think the consequence of many of the stomach ulceration, inflammation, reflux, and of course esophageal stomach cancer always come how you live your life. So in United States, some of the associated factor is chronic smoking, as well as chronic regular alcohol use. Then this associated with other type of dietary intake, such as salty food or smoked food, has been attributed to this.
Yeah, this was a big deal back in the early 1900s when there were a lot of nitrites and nitrates in food, and it's probably one of the reasons why there was such a high incidence in the U.S. of gastric cancer. And we still use those in our food, but it's much lower than it was in the past. So.
And I think it's also have to do with the type of the work we do. The old time they used to see in coal mining, or people work in with asbestosis, as well as other mining, as well as depending on the industry, they were seen more, and still you see it in Asia and other places. So what you're eating, as well as the lifestyle is very important. If somebody has a family history of stomach cancer, that is more over there. So if you have any, just by itself, you have no symptom, you have family stomach cancer, I think you should be screened for stomach cancer and finding the the H. pylori or any precursor or biopsy to make sure you don't have any precancerous cells in the stomach lining. And that's also another way to prevent stomach cancer.
So we don't want to miss the big ones here, the big things that can be prevented to try to reduce this disease. So there is strong evidence that obesity, and as obesity increases, the risk of gastric cancer will increase. Alcohol and smoking are also important.
Fatty meals.
And fatty meals. Abbas, do you think for the smoking, do you think it's the smoke that's partly inhaled and goes into the esophagus, or products from the tobacco directly into the stomach, or do you think it's more of a systemic issue that causes the risk of gastric cancer?
I think both. I think once you have a puff of smoke, whether from any nicotine, as it gets some, of course, it goes in the stomach, and when it goes to the stomach, if you have any inflammation, I think it delays the repair of that, and we see that with the smokers that, for example, if they have a common stomach ulcer or gastroesophageal reflux and ulcer, the healing process takes much longer to do, because as the repair cells come to the surface, they get killed and they delay that. That's by itself and causes chronic. But at the same time, with the chronic smoking, as absorbs through the vascular systems, it circulates through all the system, and the in the macrocirculation causes inflammation, and that's by itself that can not only cause stomach cancer, and causes many other type of cancer, whether it's bladder or kidney or associated with many other things. So I think both the direct and circulatory effect of that, and also with lifestyle. If you look at smoking, it's not by itself smoking, but most smokers, they don't eat breakfast, they eat mostly soda, they eat late at night. So those is a combination of the lifestyle that can cause the increases of the cancer, not only in the stomach as well as other parts of the body.
So I was recently very privileged to receive a gift of oranges from Abbas, who grows oranges on his farm. And one of the things I came across was that vitamin C is maybe protective against gastric cancer. So probably by neutralizing some of those nitrates and nitrates and what we call nitrosamines that are very damaging and inflammatory to the tissues. So vitamin C. So next time you eat the orange, you are protecting yourself.
And all the vegetable and fruits, I think the incidence is definitely lower to people that they consume adequate fiber as well as fruits compared to the animal product, and particularly fatty meals. I think fatty meals, and also not only itself, but it's if it is smoked, and also it delays gastric emptying. So the consequence, the contact of the food with the lining is prolonged. I think that's maybe, of course, we need much more research on that, but it's the lifestyle. I think is, if you get the fatty meals and you smoke and have even regular alcohol and not adequate, fiber, particularly the vitamin C and other things that can cause the precursor. And one of the studies actually was come across how to prevent the intestinal metaplasia in the stomach. One of the treatment, they tried the vitamin C, and that's what with the orange and the other thing that maybe that's was somewhat helpful to do that, but we need more conclusive studies to see if those really works or not.
And for vitamin C, remember, it's not just oranges. The orange marketing folks have done a good job to show that oranges have a fair amount of vitamin C, but there's a ton of other fruits and vegetables that have vitamin C.
Right.
Broccoli has vitamin C. Many fruits have vitamin C.
Exactly. Yeah.
So it's not just oranges.
Just everything. Many. As like I think it's healthy diet and fruit and vegetable and that promote motility and transit through the intestine and causes the filaments that the fruit and vegetables they do to the line and improve the barrier mechanism. So I think that's not only for stomach, small intestine, and colon is always helpful.
Do you recommend your patients take aspirin, such as a baby aspirin, for prevention of gastric cancer or colon cancer?
This is a difficult topic to talk. So if they're very high risk, maybe in some study beneficial, but however, all of these things cause increased GI bleed. So if you happen to take aspirin and had an aches and pains, take non-steroidal, and if they had H. pylori, then that will increase the stomach bleeding and GI tract. So I think they have done many studies in colon polyps as well as other things to use, whether the aspirin or any anti-inflammatory. It shows, but at the same time it increases the intestinal bleeding. So I do not commonly recommend that. I think improvement of the other lifestyle is much better. And quit smoking, drinking less alcohol, not eating late at night, doing fatty meals, and those I think much more helpful than anything else. Also, you need to look at people with other genetic markers such as Lynch syndrome or Peutz-Jeghers or polyposis syndrome. I think all of those things, if they have such a family, they should discuss with their doctor whether they're at increased risk of stomach cancer. But definitely those people from Asia or people that have family history of stomach cancer, at least deserve one endoscopy or one preventive study to be done. So if there is find something early, they can be follow up closely, because as I said, the stomach cancer by itself, it has no symptoms, just like colon cancer. By the time you get the lining stomach is such a big lumen, by the time cancer grows, and whether it causes blockage or whether it causes hemorrhage or whether it prevents you from getting full, usually you are pretty much near the stage 3 or 4, I think.
I totally agree about your comments with the aspirin. I received this question quite a bit, and there's a fair amount of evidence for aspirin as an anti-inflammatory. However, there is also it's very small, but there's a tiny risk of brain bleeding with aspirin as well. It's small, but yet it's such a severe complication that I find that the anti-inflammatory diet that we've been talking about, and I refer the listeners back to the previous episode where we talked about the Mediterranean diet and other healthy diets, just such a better way without really any risk at all to reduce one's inflammation and reduce a lot of the risk of these cancers.
Definitely. I think it just always comes to the lifestyle, and I think these are not one meal, one smoked food doesn't get you sick, one a big meal doesn't. This is the chronic use of the same thing over and over and over. So yeah, if you smoke your food frequently, or with it, of course, comes alcohol, then you smoke cigarettes. So this prolonged repetitive damage that can cause stomach cancer. With H. pylori, the same thing. It's not you once you get H. pylori, you're gonna get stomach cancer. It's untreated and repeated infection. Or we have certain people with H. pylori that they are resistant to treatment, and that can cause these precursors, as well as other autoimmune diseases like pernicious anemia, which is the lining of the stomach, can be sort of attacked by inflammatory from the body. So those are the stuff also can cause the precursors to stomach cancer as well. So if you have any family that, or you have a history of pernicious anemia, then I think you need to be go under surveillance examination to prevent. And if you do have these early stages, so you can be treated much more effectively.
Thanks everyone for listening. If you have a moment, we'd really appreciate if you could leave a review on Apple or Spotify. That'd be great. Helps other listeners find us in the search algorithms. And please feel free to share this with your family and friends. We really want to create a forum and an active discussion about lifestyle medicine. Thanks again. And
also, we'd like to hear if you have any comments, as well as if they want to hear about any special topics that they're interested that we have not covered. We'd be glad to research it and have it in our future podcast. I think our next podcast is going to be about pancreatic cancer, I hope you have a good day, and we'll talk to you on the podcast next time.
Thanks, everybody.